Well, great. Thanks so much, Pedro. And now for something completely different. And I'm glad I don't have to debate anybody. So what I'm going to talk about now is something you've heard a little bit less about, but that is referring to the potentially upcoming and practical use of post-PCI physiology to improve outcomes in patients undergoing PCI. Okay, there we go. So we think we do a great job with PCI, but for a variety of reasons, a lot of patients have recurrent angina. And actually, the more and more you look at this, the more you see that about 20 to 40% of patients within 1 year have recurrent angina. And yes, some of this is because of microvascular disease, and or vasospasm and other phenomena we're really learning about. But a lot of the reason is that we don't do as good a job treating epicardial coronary artery disease as we think we do. So there have been a number of registries that have actually looked at this with either FFR or with IFR, and in about 10 to 20% of so-called successful PCI cases, just in the target vessel alone, the vessel is still ischemic. So these are several of the registries here showing some of that data. And we wanted to really prospectively define this. So Alan Jeremias and I ran a study called Define PCI, where we, in a multi-center fashion, took 500 patients with both stable and unstable angina, and we did a spot IFR, and we found significant lesions. The IFR was less than or equal to 0.89, and then we told the operators to do PCI per standard of care. They could use intravascular imaging, but just get an optimal PCI result. And then we did a blinded IFR with an IFR pullback. So the operators were not being biased, and treated the patients with medical therapy and followed them for 1 year. And what we found was the baseline IFR was 0.69 was the mean, and it rose to 0.93 after the procedure, but 24% of the time it was still less than or equal to 0.89. So about a quarter of those vessels that had, quote, an optimal PCI result still had an ischemic IFR. And when you looked at whether or not those abnormalities were focal or were diffuse, with focal being defined as a step up of 0.03 units within a 15 millimeter segment, about 82% of the time it was a relatively focal lesion. And in about a third of the case, the focal lesion was proximal to the stent. About a third of the time, it was within the stent. About a third of the time, it was distal to the stent. So you could actually come up and say that, well, we could probably make those focal lesions better. Either you have to put another stent in to treat focal areas of ischemia, or you can improve stent under expansion or whatever is causing the problem in the stent. And if you could treat all of those residual focal disturbances, you could theoretically reduce the rate of residual ischemia from 24% to 5%. And as usual, as we've learned with everything in physiology, you can't tell from the angiogram which of the vessels are ischemic or not. Looking anywhere up and down the vessel, whether or not the QCA diameter stenosis anywhere was always less than 30% or greater than 50%, that did not reliably predict an IFR of less than or equal to 0.89. So here, for example, is a case from Define PCI, and you could see it was a tight distal LAD lesion. The IFR in the distal vessel was 0.39. And we're talking about trying to normalize the IFR in the entire vessel, because that's ischemia. So of course you say, well, there's the severe lesion, and so the operator treated that lesion with a long stent, okay, 2.5 stent, post-dilatation, got a nice result. And the IFR blinded now is 0.74. Okay, so still highly ischemic vessel despite that. And when you looked here, where was the problem? Believe it or not, most of the problem was actually in this one area, proximal to the stent, that looked like it was about a 30% residual stenosis that wasn't treated, but it actually was a very severe lesion with a very severe step-up. Now, we actually looked to see what was the optimal IFR that then predicted long-term outcomes, in particular cardiac death or spontaneous MI. And it actually wasn't 0.89, it was 0.95. suggesting that if you could really get nearly normal, normal of course is 1, but if you could really get to 0.95, you would minimize the likelihood of patient having cardiac death or spontaneous MI. And here are the 1-year curves of spontaneous MI or cardiac death. 3.2% if you had an IFR of less than 0.95, and 0% if you were above 0.95. And if you look at death, spontaneous MI, or clinically driven target vessel revascularization, again, a significant difference. So it's not just repeat revascularization, it's more heart events. In addition, if you took patients that were severely symptomatic, and I won't go through all the data on this slide, but the bottom line is by getting above 0.95, you could make patients asymptomatic. Where if you were highly symptomatic and you were below 0.95, in this series, there was still about a 12% incidence of angina at 1 year. So here's another case example. Here's kind of a diffusely diseased LAD, and the IFR was 0.88. Okay, and here is the post-PCI result. Okay, so think to yourself, is this pretty good? Do you want to leave this? Do you want to put more stents in it? Well, here, the blinded spot IFR was 0.9. So not 0.95, but at least it's above 0.89. Okay, and when you look to see where the lesions were, you can see there was a 0.05 step up distal to the stent. The stent was pretty good. There was no step up in the stent, and then there was a 0.05 step up proximal to the stent. So now look carefully, and you can see, yeah, there's 30% stenoses proximal and distal to the stent. But the operator already put in a really long stent, and he didn't want to put in 2 more stents. So he left it alone. And what happened? 41 days later, the patient came back with a target vessel myocardial infarction with what looked like a thrombotic lesion distal to the stent. And then what did he do? Then he put in 2 more stents, 1 proximal and 1 distal. So IFR co-registration has made this much more facile when we're trying to assess these lesions, and it lets us do interventional planning to see how much of the ischemia can we eliminate. And you've seen this in the Philips system, where when you assess the IFR on a co-registered pullback, it gives you all these dots, and each of the dot represents 0.01 hemodynamic units of the IFR. So here, for example, is a distal IFR of 0.63, and across this selection, you could see that's a 0.32 drop. So most of it is right in there. And you can see at each point, the dots line up on top of each other. So you can imagine that if you were to eliminate all of that, all you've got left is these 3 little distal dots. So you should be at 0.97 when you're done. That would be fantastic. On the other hand, here's a more diffusely diseased vessel in the LAD, and the operator was planning on stenting across this white line with a 38 millimeter stent, and you would see that would improve the IFR by 0.16. So that would get you to 0.91, but that wouldn't get you to 0.95, kind of our magic number. And to do that, you'd have to treat either more distally, or more likely you would treat the more proximal lesions. So, as I mentioned here, you'd expect the IFR of 0.97 after a 24 millimeter stent, but here after a 38 millimeter stent, you only expect an IFR of 0.90. Not terrible, but not optimal. So with this in mind, we have run the defined GPS, or guided physiologic stenting trial, where we took 2,151 patients with either chronic or acute coronary syndromes, and we randomized them 1-to-1 to either IFR co-registration guided PCI with GPS, or standard of care PCI. You can use intravascular imaging in both of these cases. And in the IFR co-register guided PCI, we would do an IFR pullback. We would do planning, as I showed you with the co-registration, and then after the procedure, we would do a pullback to see if there's any residual disease that we've left, with the goal of trying to get to an IFR of 0.95. So we would do much more aggressive stenting to do this. We would treat a lot of lesions that you would probably normally leave alone, and we would also really try to optimize the stent. And if we saw problems with physiology, that would actually prompt use of intravascular ultrasound, or OCT, if the operator had not used imaging before. So it's really a much more aggressive approach to treating coronary disease to try to really optimize physiology. The primary endpoint is MACE at 2-year follow-up, and I'm really proud to say that we've finished enrollment in this trial, and we're now in the follow-up phase. So probably in about a year and a half, we'll get you the results of defined GPS. So in summary, invasive pressure wire-based physiology is currently used principally to assess the hemodynamic significance of focal stenosis to guide lesion selection prior to, but for PCI. A substantial proportion of vessels after PCI remain ischemic, which may in part explain recurrent angina and contribute to increased MACE rates during follow-up. IFR pullback can be used for interventional planning prior to PCI and to assess residual ischemia after PCI, the optimization of which may improve patient event-free survival. And we've now completed enrollment in the pivotal defined GPS trial in more than 2,000 randomized patients to answer this question. Thanks very much.